If you like, you may open the full text article to follow. Here's the link, or you may use the search terms to follow my slides and the process what I'm talking about. So we will follow the same structure as we did for therapy articles, which was starting with the validity. Is this study valid? Are the results of the study valid? If we are speaking of validity, which section of the paper, of the manuscript, we need to look at? It was the method section. So I will take the method section and critically appraise it for this purpose. Which questions I need to answer? Was a defined representative sample of patients assembled at a common point in the course of their disease? So if they were all new patients, or old diagnosed patients, or very old people, or very young people, or certain race, that all might make sense for yourself. So you need to know, first of all, about the representativeness of the sample. Who were the participants of the research? Second, was follow-up of study patients sufficiently long and complete? So what about the follow-up? The second question. Then, were objective outcome criteria applied in a blind fashion, blinding, although these prognostic studies are usually cohort studies. We are expecting to see clinical cohorts or cohort studies. Here also we may apply the blinding. And fourth, if subgroups with different prognosis are identified, was there adjustment for important prognostic factors? Because if the groups are different, groups with the risk factor, without the risk factor, with positive cellular markers in this case, and negative cellular markers, if one group is rather older compared to the other group, that might affect or be related to the mortality, to the outcome. Therefore, during the analysis, we need to follow a procedure which is called adjustment. That means to try to equalize the both groups when we are comparing. And then was there validation of an independent group of test set patients? The structure of assessing validity is always the same. We have the study population, the target population. We regard this as infinite. That means there are many potential people. From them, we select a sample. That's usually the people applying to the hospital, if you are in a hospital setting. So people coming to your clinics. And then you select your sample. And first point, as I said, is to check whether this sample is representative of the study population. If this is not the case, we lose some of our validity, of course. Second, is my sample homogeneous? If they are very diverse and different background participants, that also might influence the validity. If you have prostate cancer patients who have additional diseases like comorbidities, heart diseases, of course, the mortality of these people might be higher compared to people who don't have these conditions. So homogeneity would be one factor you should consider. Then we have the two or more groups which we are comparing. Here for example, positive cellular marker and negative cellular marker, or marker X, marker Y, whatever you are comparing. And these two groups, during the analysis, they should be adjusted. They should be concerning the confounding factors, related factors, they should be similar. If they are not similar, there are statistical methods to do this analysis, and during the analysis, we need to adjust the groups. Otherwise, our comparison would be, of course, open for critics. And follow-up. Is it complete or not? Do we have a complete follow-up, or are there dropouts in the different arms? What about the different dropout ratios? Are they high or low? And the outcomes, of course, should be objective and unbiased. So let us repeat once more. Was the sample of patients representative? Were the patients sufficiently homogeneous with respect to the prognostic risk? Follow-up, was it sufficiently complete? These, of course, sufficient, when I say sufficient, these are rather subjective terms. So there is no certain criteria. I will not give you a statistical threshold or limit for sufficient, sufficiently homogeneous or sufficiently complete. But a clinician should be able to judge for himself. And were objective and unbiased outcome criteria used? So as I said, we need to focus on the method section of the article. And if you look at the method section of this article, which we retrieved, you see that in figure 1, there is a flow diagram, which tells us how many people with prostate cancer were diagnosed. So these were, during this time interval, 4 years, 5 years time interval, they had 1,313 prostate cancer diagnoses. Of course, these 1,300 are not representing the whole population. There are many in the community, in the city where this research was done, in the country, worldwide. There are many other people. So this we can call N. And is this 1,300 people similar to this general population? If not, if this is a certain race, for example, or certain subgroup of people, then we have to be careful because it may not fit to our own context. Okay. Now they had this 1,300. Then some of them they had to exclude because of problems with the records, etc. And how many they included for clinical assessment? 1,270. Some of them they could again not analyze because some other factors, or approximately 100. And at the end, they analyzed 1,007. So there is approximately out of 1,300, 300 dropouts or losses, or people who could not be included in the analysis. Is this okay for you? That's a question you yourself have to answer, of course. I would say this is, for my clinical sense, perception, I would say this is in a threshold. It is not negligible. 300 people out of 1,000 could not be included in the analysis. This is not less, but at the end, they have a very high number of participants. Therefore, I would still consider this in the scale of validity. I would consider this above 50% or near to the valid part. Were the patients sufficiently homogeneous with respect to prognostic risk? Where do we look for this? There are in all publications, there are these characteristics of participants. This is usually the table 1. In the table 1, you see the different demographic features of the participants. For example, the mean age or median here, median age is 72, and PSA levels were measured as 10. What else? And moderately, most were moderately differentiated cancers. So this table should give us an information about the homogeneity of my participants. Some information about that. Then follow-up and outcome criteria. For this purpose, I need to read in more depth the methods section. In the methods section, I pasted here the 3 following slides from the methods, and I will not read it sentence by sentence with you, but I want you to see how, what kind of information is presented. You see, they have reported the total number of male veterans ambulatory came to the hospital, 64,000, and among them they had 1,270. So the sources of information, paper-based, electronic medical records, etc., and then how they extracted the data from these resources, from these records, and what kind of information they recorded, age, race, you see, comorbid conditions. These are all relevant for us to come on a conclusion about the validity. Then histological grades, anatomical extent they have recorded. What else? PSA levels they have recorded. What else? Other factors, etc. Okay. Further, in the methods, they mention we also requested diagnostic tissue blocks and slides for the man. So they have also revised the pathological diagnosis from the needle biopsies. And which kind of markers they have measured. Here it is, BCL2. The tissues were evaluated for BCL2 and some other factors. Okay. A pathologist blinded to patient outcome did all of the readings. So again here, blinding, very important. And when I see that the pathologist was blind, because if the pathologist would have been aware of the outcome, there is mortality or not, if the patient has died, the pathologist might be biased in his interpretation. It is very important that it is biased and blinded, and that is mentioned here. What else? This is my last slide from the methods. We assess the vital status of each patient by using the VA patient treatment file, the VA beneficiary identifier locator system, and the national death index. So they made sure about the outcome. Was the patient alive or dead? Death from prostate cancer was determined while investigators were blinded to the marker status. This time the reverse, the pathologists were blinded for the outcome. Here the investigators were registered the outcome status of the participant, of the patient. They were blinded about the marker status, whether the marker was positive, cellular markers were positive or negative. Okay, so that much information I think is enough for me to conclude whether this research is bringing me valid evidence or not. Would you say it is valid?